Hello everyone, this is Rania, and today we are kicking off the very first video in our series on multiple myeloma. This is going to be a journey where we break down complex medical concepts into clear, digestible pieces. So grab a cup of coffee, stay curious, and let's dive in. Multiple myeloma is a clonal malignancy of plasma cells. In simple terms, it's when plasma cells in the bone marrow start multiplying uncontrollably. These malignant cells crowd out the healthy ones, disturbing normal blood cell production. That's why patients often experience anemia, weakened bones, immune suppression, and even organ dysfunction. Think of it as the bone marrow being hijacked by plasma cells that refuse to follow the rules. Multiple myeloma is one of the most common blood cancers worldwide. Men are affected more than women, with a ratio of about 1.6 to 1. The median age at diagnosis is around 69 years. So it's typically a disease of older adults. Interestingly, prevalence differs across populations. Africans are more affected than Europeans, who in turn are more affected than Asians. And here's a key point. First-degree relatives of patients with plasma cell disorder have up to fourfold increased risk. So genetics definitely play a role. All blood cells start from a single stem cell. From there, two main paths emerge. The myeloid lineage, which produce red blood cells, platelets, and granulocytes, and the lymphoid lineage, which produce B cells, T cells, and natural killer cells. B cells can further mature into plasma cells, the very cell involved in multiple myeloma. In short, this diagram shows how one stem cell gives rise to the entire blood cell family. Now let's talk about what's happening at the cellular level. Multiple myeloma develops through a multi-step process. It often begins as MGUS, or monoclonal gammopathy of undetermined significance, which progress at a rate of about 1% per year. Over time, immortalizing events like chromosomal translocation, oncogene activation, and loss of tumor suppressor regulation push the MGUS into full myeloma, and in some cases, plasma cell leukemia. Why does multiple myeloma wreak havoc on bones? It's all about imbalance. Osteoclasts, the cells that break down the bone, become overactive, while osteoblasts, the builders, slow down. The result? Weak bones, lytic lesions, fractures, and hypercalcemia. That's why bone pain, especially in the spine and chest, is such a hallmark symptom. Because bone damage is such a central feature of myeloma, bone protection is a critical part of the management. Treatments like bisphosphonate or denosumab are used to strengthen bones, reduce fractures, and help control pain. We will be discussing bone protection strategies in much more detail later in this series. Patients often present with bone pain, particularly in the spine or chest. Fatigue and weakness are common, driven by anemia. Weight loss can also occur. Labs tell the story. Serum calcium is elevated due to bone breakdown. Hemoglobin is low thanks to increased hepcidin and inflammatory cytokines. Creatinine levels rise, reflecting kidney involvement, and immunoglobulins are elevated. But here's the catch. They are produced by malignant plasma cells and are non-functional. So even though there is more protein, the immune system is weaker. In the bone marrow, we see clonal plasmacytosis, meaning plasma cells make up more than 10% of the marrow. These cells typically produce either kappa or lambda light chains. Immunophenotyping shows they are CD138 positive, CD38 positive, CD45 negative, and CD19 negative. About 70% of patients also express CD56. These markers not only help confirm the diagnosis, but they are also clinically important because many of them serve as therapeutic targets. For example, CD38 is the target of monoclonal antibodies like daratumumab, and CD138 is being explored in novel treatment approaches. So the same markers that help us identify multiple myeloma cells can also be used to fight them. To officially diagnose multiple myeloma, we use the SLIM CRAB criteria. CRAB stands for end organ damage. Calcium is high, over 11.5 milligram per deciliter. Renal insufficiency with creatinine more than 2 millimole per liter or creatinine clearance less than 40 ml per minute. Anemia with hemoglobin less than 10. Bone lesions visible on imaging. And SLIM adds biomarkers. More than 60% plasma cells in the marrow, free light chain ratio more than 100, and MRI showing more than one focal lesion. Together, these criteria ensure we catch the disease early and accurately. Once diagnosed, we stage the disease. Staging helps us protect prognosis and guide treatment decisions. Newly diagnosed patients are classified based on lab values and imaging findings, which we will explore in detail in later videos. Finally, risk stratification. This step is crucial for counseling patients and tailoring therapy. It helps clinicians decide not just what treatment to use, but in what sequence to maximize benefit and minimize toxicity. And that wraps up part 1 of our multiple myeloma series. Today we covered the basics: definition, epidemiology, pathophysiology, clinical presentation, and diagnostic criteria. In the next videos, we will dive deeper into staging, treatment strategies, and emerging therapies. Thanks for watching, and don't forget to subscribe so you don't miss the rest of the series. See you in part 2.